Welcome to Uniquely Spoken Podcast, empowering healthcare, where transparency sparks transformation. Are you ready to dive into conversations that will spark ideas and inspire action? This is a podcast that refuses to accept the status quo. Welcome back. This is episode 19, when nursing homes eliminated unit clerks. The hidden cost nobody measured. Most people have never heard of a unit clerk. Yet for decades, unit clerks served as the administrative backbone of nursing homes, rehabilitation centers, and skilled nursing facilities. They answered phones, coordinated transportation, managed schedules, processed paperwork, communicated with pharmacies, and absorbed countless interruptions before those interruptions ever reached clinical staff. Then quietly, many facilities eliminated the position. The question is simple. What happened after that? On paper, the unit clerk wasn't a clinical position, but the role touched nearly every part of facility operations: admissions, scheduling, transportation, order transcription, family communication, supply coordination. The clerk sat at the center of a web of activity. Their job was simple: keep information moving so nurses could focus on care. The most important work often happened behind the scenes: staffing schedules, survey preparation, compliance documentation, pharmacy coordination, dialysis logistics. These responsibilities were largely invisible until they disappeared, because when no one is assigned to perform them, they don't go away. They get transferred. One Colorado nursing home offers a glimpse into what happens when clerical support is restored. Columbine West Health and Rehab found that admission paperwork was consuming enormous amounts of nursing time. After adding dedicated unit clerks, overtime decreased substantially. Workflow improved. Nurses spent more time providing care. While this was a single facility, it raises an important question. If adding clerks produce measurable benefits, what happens when they are removed? The answer begins with economics. A unit clerk's salary appears clearly on a budget. The downstream consequences often do not. Overtime, scheduling errors, care coordination gaps, documentation delays. These costs may emerge months later, but the salary reduction appears immediately. The burden shift. The position disappeared. The tasks did not. Documentation moved to nurses. Scheduling calls moved to nurses. Supply coordination moved to nurses. Family communication moved to nurses. The work was redistributed, not eliminated. Electronic health records were supposed to streamline health care. In many ways, they did. But they also introduced new documentation demands. Research shows nurses spend substantial portions of their shifts entering and retrieving information. Technology changed the form of the work. It did not necessarily reduce the quantity of the work. Medication administration depends on attention. Every interruption competes for that attention. Phone calls, scheduling questions, family inquiries, supply requests. Research consistently links interruptions with increased medication error risk. The issue isn't a single phone call. It's the cumulative effect of hundreds of interruptions over time. Dialysis residents require coordination across multiple organizations: the nursing facility, transportation providers, the dialysis center, families, clinical staff. When communication breaks down at any point, treatments may be delayed or missed. What looks like scheduling is often patient safety. Administrative overload has consequences. Documentation fatigue, stress, job dissatisfaction, turnover. Every additional non-clinical responsibility competes with the work many nurses entered healthcare to perform. The consequences extend beyond a single nurse or a single shift. Care coordination failures, operational inefficiencies, emergency transfers, readmissions. These outcomes affect residents, families, facilities, and healthcare systems alike. The story we've told so far is largely from the perspective of the nursing unit, but that's only part of the picture. To understand why so many facilities eliminated unit clerks, we also need to understand the reality facing administrators. And that reality is complicated. Many nursing homes operate on extremely thin margins. Labor costs continue to rise. Medicaid reimbursement often fails to keep pace with operating expenses. Workforce shortages remain persistent, and regulatory compliance requirements continue to expand. Administrators are asked to maintain quality, meet staffing expectations, control costs, and remain financially viable, all at the same time. From that perspective, eliminating a non-clinical support role can appear reasonable. A unit clerk's salary is visible, measurable, and immediately reflected on a budget. The potential consequences, however, are often less visible. Those consequences may not appear until months later. Increased overtime, higher turnover, coordination failures, documentation delays, and additional pressure on nursing staff. The challenge is that both realities can be true at the same time. Facilities face genuine financial constraints, and nurses face genuine workload burdens. The question isn't whether administrators care about resident safety. The question is whether the full cost of eliminating clerical support is being measured accurately. Because what appears to be a savings on one side of the ledger may create expenses somewhere else. So where does that leave facility leaders? The first step is measurement. Before eliminating support positions or deciding not to replace them, facilities should understand exactly where nursing time is being spent. How much time goes toward admissions, scheduling, phone triage, transportation coordination, documentation, and how much time remains for direct patient care. Second, pilot solutions. Not every facility needs a full-time unit clerk on every unit, but a limited trial can provide valuable information. A shared clerical role, a floating coordinator, or support during high-volume shifts. Small changes can produce measurable results. Third, clarified delegation. Every task performed on a nursing unit should be evaluated. Does this require a nursing license, or does it simply require someone to own the responsibility? Fourth, protect nurses during the highest risk periods. Medication passes, shift changes, admissions. These are moments when interruptions carry the greatest consequences. And finally, don't assume technology is a substitute for coordination. Electronic health records can improve documentation, but they cannot replace the human work of communication, scheduling, follow-up, and problem solving. Those responsibilities still belong to someone. At first glance, the math appears straightforward. Remove the salary, reduce expenses, save money, but healthcare operations are rarely that simple because every decision has downstream effects. A facility may eliminate one position, only to see overtime rise, turnover increase, or coordination problems create new inefficiencies. A missed appointment, a delayed discharge, a medication issue, a preventable hospitalization. Each has a cost. Some costs are financial, others are operational, and some are measured in resident outcomes. The difficult question is whether the apparent savings were actually savings at all, or whether costs simply shifted from one department to another, from a budget line to the nursing unit, from an accounting report to the daily realities of patient care. Let's return to the central question. What happened when unit clerks disappeared? The answer is not that the work disappeared. It didn't. Admissions still had to be processed. Transportation still had to be scheduled. Families still needed updates. Pharmacies still needed calls returned. Compliance documentation still needed to be maintained. Dialysis appointments still had to be coordinated. The work remained. What changed was who performed it. In facility after facility, responsibilities that once belonged to dedicated clerical staff were redistributed, often to nurses, often without reducing any of their existing clinical responsibilities. That's the hidden reality behind this story. The position disappeared. The work did not. And the question every organization should ask is simple. Who owns that work today? And what is the cost of asking clinical staff to carry it? Sometimes the clearest stories are told through numbers. Healthcare organizations spend enormous resources recruiting and retaining clinical staff. Yet workload remains one of the strongest predictors of burnout and turnover. Every hour spent on non-clinical work is an hour not spent delivering care. Every additional administrative burden competes for time, attention, and energy. Turnover carries costs, recruitment costs, training costs, orientation costs, lost productivity, and operational disruption. The challenge is that many of these costs are indirect. They're harder to see than a salary line on a budget, but they are costs nonetheless, which is why the burden shift deserves closer examination. Because what appears inexpensive on paper may prove expensive in practice. There is another important factor in this discussion: regulation. Healthcare staffing requirements focus heavily on clinical staffing levels. Registered nurses, licensed practical nurses, certified nursing assistants. These roles are measured, tracked, and regulated. But no comparable standard exists for unit clerks. No federal requirement mandates clerical coverage. No staffing formula accounts for administrative coordination. And no regulation measures the amount of clerical work transferred to nursing staff. As a result, a facility can appear fully staffed according to regulatory metrics, while simultaneously placing significant administrative burdens on nurses. That creates a blind spot, not because regulators intended it, but because clerical coordination was never a major part of staffing calculations. And yet the work remains essential. Every day, on every unit. If there's one lesson from this story, it's that accountability starts with measurement. Before leaders can solve a problem, they must understand its true scope. How much nursing time is spent on administrative work? How many interruptions occur during medication passes? How much coordination is required just to move residents through the healthcare system safely? These questions matter because they reveal where inefficiencies exist and where support may be most valuable. Organizations can conduct time motion studies, pilot clerical support models, clarify delegation practices, and examine which tasks truly require licensed clinical staff. The goal is not necessarily to recreate the past. The goal is to understand the present and make informed decisions about the future. because healthcare systems work best when responsibilities are intentional, clearly assigned, and adequately supported. The story of the unit clerk is not really a story about one position. It's a story about work. Work that once had a name, work that once had an owner, work that often happened quietly, in the background, without recognition, without praise, and without much attention, until it disappeared, or at least until the position disappeared, because the work never actually left. Someone still schedules transportation. Someone still tracks paperwork. Someone still updates families. Someone still coordinates appointments. Someone still manages the countless details that keep a nursing unit functioning. The question is no longer whether that work exists. The question is who performs it and at what cost. For residents, for families, for nurses, and for the healthcare system itself. Perhaps that's the most important takeaway from this entire discussion. The position was eliminated. The work was not. And until healthcare organizations measure that work honestly, the true cost of eliminating the role may remain exactly where it has been all along, hidden in plain sight. The story of the unit clerk is not really a story about one position. It's a story about work. Work that once had a name. Work that once had an owner. Work that often happened quietly, in the background, without recognition, without praise, and without much attention, until it disappeared, or at least until the position disappeared, because the work never actually left. Someone still schedules transportation. Someone still tracks paperwork. Someone still updates families. Someone still coordinates appointments. Someone still manages the countless details that keep a nursing unit functioning. The question is no longer whether that work exists. The question is who performs it and at what cost. For residents, for families, for nurses, and for the healthcare system itself. Perhaps that's the most important takeaway from this entire discussion. The position was eliminated. The work was not. And until healthcare organizations measure that work honestly, the true cost of eliminating the role may remain exactly where it has been all along, hidden in plain sight. I am Juanita, the founder of Uniquely Spoken LLC. I started this podcast to ignite change in healthcare, starting with long-term care settings. It is time to transform nursing homes and rehabilitation centers, assisted living and memory care communities to all become premier long-term care settings nationwide. It is time for all long-term care settings to receive a 5-star quality and customer service rating. It starts now, and it starts with me. It starts with you, and you. And the time is now. Thank you for joining us. We broadcast every Tuesday at 8:30 a.m. Eastern Standard Time. Don't forget to join the conversation, request to be a speaker, and partner in transforming long-term care settings. And don't forget to tune in next week. Thank you for joining us on Uniquely Spoken LLC podcast. Please subscribe on Spotify, Apple Podcasts, or wherever you listen. Remember to connect with us. Follow, comment, subscribe, share, be a guest. Visit us at uniquelyspokennllc.com/podcast. That's UNIQUELEESPOKEN llc.com/podcast. Or if you are a viewer, scan our QR code. Please remember to stay informed, stay empowered, and keep the conversation going. We love hearing from you, and we'll see you next week.